So now that we gave you some background on digital dentures and maybe that they are viable not only to use for all denture applications, but maybe because of strength to use in implant restorations, let's go through a case. So we'll do like a freehand case with digital dentures. And the next couple of slides, I'd like to thank my friend James Angelone, the denture man. We do a lot of guided cases at the lab as well as regular conversions, and James had some great slides of a case he did recently. James is a fan of iVotion, and he feels doing this. He's a gentleman that has a van totally outfitted with technology and goes from office to office helping to convert the cases. And he doesn't want to do things twice, nor do I. So when he does a freehand case, he prefers doing the iVotion digital denture cases because of the strength, and which I'd like to show you here in the next couple of slides with the procedure. So I'm not going to spend a lot of time on the freehand technique. I told you I'm going to share 3 techniques with you. So I'm not going to spend a lot of time on this one because it is what you're probably the most familiar with if you're doing full arch dentistry, a normal conversion. But this is a great slide showing how this shell geometry works, and that this is actually in pictures of the nesting software. So that is the design denture that we've created, and we've moved it up and down in the puck. So the top circle and the bottom circle represents the dimensions of the puck, and we've moved the prosthetic up and down in the puck to position it within the white of the teeth so that we could get the incisal edge at the right place and have the cervical stop where it needs to stop and have the gingiva begin. It was very interesting technology and pretty impressive whoever created this. So normal immediate load pickup situation, immediate denture is done ahead of time. In this case, it was done with iVotion. Could have been milled out of a full arch PMMA puck, or could have been printed. If it was printed, I definitely would suggest using one of those newer, stronger materials, such as carbon, the Dentsply carbon. So you would take a reline impression inside of this, place it over the comfort caps to identify the implant positions. So went ahead and James went ahead and drilled where these tooth implant sites are to expose them. And then they're greater exposed, you create an area to pick up the temporary cylinders. I think this is really the slide I wanted to show you in this series, but as you can see, these holes are going right through the middle of the teeth. And there's many areas of there where it's just a very small piece of white tooth material in the tooth and not a lot there. And if we were to do this in a injectable system, such as like the IVO-based system we use as a comparative, or even worse in a press pack system, those areas would be very weak and very subject to fracturing significantly. The isthmus between some of those areas are not very large, and you want to really get concerned to how much acrylic is actually holding this thing together. But when it's milled in a solid block, those concerns kind of melt away, and that there's really no weak spots other than the area. And that initial research, like I mentioned, showed that even with the holes in it filled with cold cure acrylic, this prosthetic had strength that was greater than any other option other than the pure iVotion case. So that was pretty compelling. So to move on in the process of these case, once the holes are created, we put the wash back on there again to pick up those locations and blocks them out a little bit further and gets temporary cylinders in there. And then they're injected with acrylic material. This can be of a number of different ways. We have 5 technicians that go out in the field and do conversions, and just like James Angelone had done this conversion, we recommend a material called Stellar. There's also a material called Boco on the market. You can use cold cure acrylic to process these. There's other materials that you can use, but you want to inject something in that definitely is going to bond to the material. With the milled dentures, it is acrylic, so it does bond quite well to all those materials that I mentioned. And then at this point, the analogs are put in, a model is created, doing an articulation of the model to check the occlusion, make sure everything is just right and just perfect, taking out the palate, acrylic cut out and finish, getting rid of the palate, and then basically finishing up the prosthetic. So then he would deliver the iVotion prosthetic without a lot of worries, because this was a digital denture milled in a solid block of material. So there's not a lot of room for areas to fail, even though they have been compromised around the implant sites because needing to pick up those parts. So another option is a guided surgery apart to digital dentures. And in fact, this is really where we got started with digital dentures. In our lab, we use a guided surgery technique. There's several techniques to do full arch guided immediate load restorations. We have one called the Guided Smile Chrome system that we advocate. And we got started in digital dentures because in order to figure out where the implant needed to go, we would set up as we should, put the teeth in the patient's mouth, put the teeth in the patient's face, and create a full denture for this case to go through the implant planning process. Well, a lot of doctors wanted to have a backup denture in case they couldn't encode the prosthetic. Initially, back in 2016, we were separately making a separate denture just in case it got used. And then when we started doing digital dentures in 2017, we said, hey, we're designing this case digitally all the way. Let's just print the denture and provide that to the doctor along with the milled prosthetic that we provided that went on to the surgical guide. So that's how we got started in digital dentures. And I'll take you through a case with this because I think it has some additional advantages. So, what is Guided Smile Chrome? It's basically the small hole technique I'm going to show you uses Chrome as its foundation. So I wanted to explain a little bit what it is as we go through those slides. So it's a pre-planned, fully guided surgical guide and a prosthetic protocol. We start with a smile simulation, and then we finish up with a full arch final prosthetic. But we delivers bone reduction, osteotomy guidance, implant control, abutment timing, simplified prosthetic conversion, a simplified method for converting the final restoration, which I'll show you how digital dentures can work better with guided cases like this. That technique is patent protected. We're pretty proud of that. Got issued earlier this year. So, I'm thinking as we're doing all this, what if, we could get the implants in the right position? We could provide a prosthetic that was strong enough to withstand the forces of occlusion and withstand time without breaking. What would be the benefits of that? If we could get everything right out of the gate. I think it would definitely decrease cost, could decrease appointments significantly for the practice, and it could have more patient acceptance because they're literally getting teeth in a day, getting teeth now. But I think the real benefit is if you get kind of a convergence of these technologies is to provide a premium treatment option, to countless patients who can otherwise not afford it. If a patient's trying to get a $30,000, $25,000, $20,000 fixed prosthetic, and they don't have the money for that, they're forced to get a 2-implant overdenture or something that is not going to change their life quite as much as a fixed prosthetic would be. Or it's something that they don't want. I mean, they want a fixed prosthetic. A lot of patients don't want to have a prosthetic coming out of their mouth. They want to have teeth in their mouth, never to come out. So it feels like they have teeth again, and they don't have a denture that's removable. So I think there's two solutions that can, with the combination of these technologies, that can really provide some unique benefits to patients. And there's a couple challenges to providing a unique benefit to patients of having a more affordable solution to full arch restoration. One is enough information. If we don't get enough information from the surgical guide out of the gate, we can't make a nice prosthetic. If we have bad records, bad bites, things are off, we're not going to get the teeth in the right position. So the challenging of getting enough information is definitely a challenge. So we definitely need accurate bite rims, spending the time telling us where the teeth should be. There's methods like the centric tray or other ways to do it. But as I mentioned before, with digital dentures, we're huge advocates of getting the patient's face in the picture, because as you can see, when we have the patient's face in the picture, we can see that this midline is going to be acceptable. The incisal length of the teeth is where we believe it will look good, where our client believes it will look good. But we can go a step further with that. And I think this technology is going to take off here shortly, is basically getting a three-dimensional picture of this patient with face scans. There's several products on the market. So this is a simulation I just put on that we've made of the patient ahead of time, but this is his 2D face with going through the thing. But we also took a 3D picture of the patient's face. And that gives a tremendous advantage over a 2D picture, where we could zoom in on this patient and look at the cuspid position. We can look at the intervertebral border. We can look at if we think it's going to fill his vestibule and hold his musculature in the right places. So we're excited about the technology improving and increasing. And this unit that we use for this was an Einstein camera. It's $5,000. It's not a ton of money. There's the Face Hunter camera from Zircon Zahn. There's others on the marketplace. We can combine simulations, all kind of information to get the information we need to get these teeth in the right place right out of the gate. So we don't have to wait till the patient heals to figure out tissue position. We can get the teeth position right out of the gate in the right position. And all we have to worry about is getting the tissue position and the healed tissue position established after the patient heals. So the next challenge to trying to get a full arch immediate load restoration right out of the gate, right from surgery to final, is fit. So, for years we always do the Sheffield test to try to get fit on restorations. And now we're doing a lot of work with iMetric and iCam using photogrammetry to establish these positions and provide design files right back to doctors' offices as they print these prosthetics in the office to go right to multi-unit abutment. So there's some solutions out here for passivity of fit that are really going to be amazing. But when you're doing if you're going to do an immediate load situation, you're going to pick that case up directly. We maybe don't have to worry about $50,000 pieces of equipment, because we're gonna pick it up right in the mouth, right where those implants are placed, and right in the healed position. So we're gonna create passivity right at the beginning, not have to capture it. And the third challenge is the materials have to be strong enough. The early digital denture materials were not strong enough. They have gotten stronger. The new milled materials, like I show, I believe they have the strength to stand the test of time. So considering getting a passive fit, stronger materials, and getting enough information out of the gate, this is one solution, is using small hole technology we call C2F. So C2F stands for conversion to final. It allows us to draw small, very small 2.5 millimeter holes in the prosthetic instead of those big holes that you saw. And that study showed that prosthetic with those large holes filled with cold cure acrylic was almost as strong as a solid mill by motion denture. Well, what if those holes were only 2.5 millimeters small and very minimal? So this will go through this case quickly. So this is an upper arch restoration. Doctor chose to use a chrome guided smile surgical protocol and a C2F extraoral conversion that I'll show you that allows these holes to be very small. And then we use Ivotion implant supported surgical prosthetic because we believe that was the strongest material at the time. So the pin guide is placed. It goes over top of the teeth. That allows us to fixate. And this is obviously a whole different lecture. So I'm going to focus on the materials and the prosthetic and not so much the surgery, but the pin guide is placed in place. The fixation base is drilled in and held in with pins to lock in that pre-extraction position. As you see here, it's held in with pins. This is the bone reduction is used. Metal is used as the bone reduction guide with the fixation base. The osteotomy guide is placed into the site, and the site implants are drilled. At that point, this is called a carrier guide. It goes back onto the fixation base. You see those little pegs there that allows the milled prosthetic to lock into place on those pegs. Once that's in place, the temporary cylinders are put in. We provide these little lockout gaskets that go over each of them. And then the immediate load prosthetic is, at that point, I'm sorry, the rapid appliance is placed, which is a duplicate of the immediate load prosthetic. This is just like the prosthetic that we created for the patient, except that prosthetic we created for the patient doesn't have holes in it, because we're going to put in very small holes in that technique using the C2F method. So we put on these little block up plungers, very similar to the conventional freehand method. Those are injected in. Sometimes we'll put portholes in the buckle if that's preferred, but material is injected in to lock those temporary cylinders in place. And at that point, a C2F model is provided. So these pegs are the same pegs that were on this carrier guide. It's going to position those teeth in the same position that they would have been in the mouth and they would have been in the pre-planning that was created. So at this point, once those temporary cylinders are done, we put C2F analogs on this prosthetic, which have holes in them that allow them to be screwed and drilled through. And this is cured onto this model indirectly in the mouth. At this time, typically the patient's getting sutured and they're starting to get ready to clean up the surgery. At that point, we have our prosthetic that's milled out of a solid block of material. At this point, it was the Ivotion DCL material. It wasn't the Ivotion disc. It didn't have that protocol worked out yet. But this is a solid monolithic block of digital denture teeth. And we use this prosthetic that we picked up in the mouth to basically create an implant model that was dead accurate, that gives us that passivity of fit that we said was one of the 3 conditions we needed to have to allow a prosthetic to really be long lasting in the patient's mouth at immediate load surgery. So at that point, we have this prosthetic that then fits onto these pegs, and the model is simply drilled out. Those analogs are 2-part analogs. So they come out from the bottom. So there's a hole in them. And one would simply drill through the bottom, almost like a drill press. They put the handpiece through a long chamber, and it drills a perfect hole in the prosthetic. And that's basically what it looked like when it's finished. So the immediate load prosthetic is created with the very small holes in the prosthetic. So we have a monolithic disc with no denture teeth, not a lot of areas for failure point, with very small weak points in the prosthetic. This can also be done a different way with conventional dentures using Dr. Koffer's smart denture conversion technique is another option that can be used. But this small hole prosthetic would allow something to be very strong, would allow the hole to be right. If we get all the right information, the right technology, the pictures, we can get those teeth in the right place out of the gate. So that with many of our guided smile surgical cases, when the patients, after they're done healing, all we have to worry about is replicating the healed tissue position. And a prosthetic like this could be relined to the healed tissue position, allowing this patient to use this prosthetic for a long time before needing it to be replaced with a definitive prosthetic. And maybe even having that prosthetic be the final prosthetic if they can't afford a solution that's made out of zirconia or alternate materials. So one would ask with Ivotion, if anyone out there is familiar with the Ivotion system, it becomes a challenge because how do you design something in the Ivotion system that's not a full denture? So that's been worked out. This is still in beta. We've done it on a couple of cases, but basically we have a digital denture design. But it's a different tooth library that we use. It has a small hex X in the tooth library. And what that X does, it puts a cross on it. So it allows us to basically reorient this prosthetic in and out of the software. So we'll design the product as normal using a unique tooth mold that has this geometry attached to it. We export that file out. We go into our third-party software and create what we need to create in the prosthetic to make it fit on our carrier guide and make the changes we need for an immediate load prosthetic without holes or without holes. Then we import that back for reassimilation into the software. As you can see, we're moving it back in with this modified design. This doesn't look like a denture anymore. It looks like a implant supported immediate load denture. So we went from the left picture to the right picture after we remodified it, but we're able to bring it back in the same position so we then can nest it within that shell geometry to make it work. That's basically how that works. Now, this won't be available till 2023 in 3Shape, but it is, it's exciting to us because it allows us to use the best technology to produce a really strong restoration. So just like I mentioned before, the ability to make a very strong restoration with small holes, it is possible to make it with no holes. And we're really super excited about further convergence of technologies. I think there's several systems that coming on the market that are going to allow this to happen. But the one that we've are very, very high on and been working with is the Rowe SmileLock system. It's made from Roto Medical, makes the product. It's called SmileLock, and it uses a unique alloy, a NiTi alloy that is a sensitive to heat. And a wand uses induction heat to lock that and take that in and out. So basically the Smile Key pushes induction heat, which their research, which is very thorough, this has been out for about 7 years now, to go to the SmileLock to allow it to unlock. So it gets placed in the patient's mouth, kind of can be picked up similar to a locator, or it could be picked up indirect with that C2F model that I showed you, that external pickup model. So it could be picked up that way or picked up like a locator. And once it's locked in the patient's mouth, it is not removable by the patient at all. It's only removable by the clinician using the Smile Key. And this technology, it holds that prosthetic in stronger than cement or screws. So this is basically the SmileLock components and how it works inside a prosthetic. So the coping obviously goes inside the digital denture. The SmileLock, it clicks into place and it fits onto unique abutment. The one caveat is that it fits with many implant systems, but it has to be used with an implant system that's compatible because they have its own abutments that provide these undercuts on it that allows the SmileLock to lock into place. But it's super interesting technology, and as soon as it's locked into place, as soon as you put it in, and once it's heated, it goes back to this shape memory. Now that technology is used in endo post, it's used in heart catheters, it's used in medicine in a lot of different ways. So it's not brand new, but it's something that we're excited about because it allows us, I believe, to make a prosthetic with no holes at all in the prosthetic. But I think that this technology allows us to have, it's a new era of patient solutions that is upon us. When we have a convergence of technologies between these, it allows us to using complementary advanced technology to maybe make a prosthetic for a patient that instead of having to pay $25,000, $30,000 for a prosthetic that if they can't afford it, they could maybe get into a solution that's going to be a really outstanding solution that's going to be strong and that is going to stand up against the test of time. And when they can have more money to get into a zirconia solution, they can. But this might be a solution that allows them to change their life quicker and easier with less appointments to both the clinician and the patient. So it's exciting using digital dentures for implant solutions. And I think that's some references that I spoke to in the program. I think that's all the information that I have to present to you today. So I hope you enjoyed this presentation. And if there's any questions, I'd be happy to look through the dialog box and see if I can answer them. So I have a few questions here coming in, but I think they mostly could be answered offline, it's, that would be probably more appropriate. So I really thank everybody for your time today. And I wish you the best of luck with digital dentures in the future. If you have any question about any of those products, I'm sure there's a lot of information on the internet. You can research it, and I can always be reached at roedentallab.com if anyone has any questions about the information provided. Thank you very much.